All right, guys, we'll get started. Welcome to our new segment, Call Through Fall. Today we are speaking with Dr. Lozada, who is a facial plastic surgeon, and we can let him introduce himself now.
All right. Hey, everybody. So my name's Kirk Lozada. So I'm a facial plastics and reconstructive surgeon in Philadelphia right now. So I work at a Penn-affiliated private practice. It's called Penn Medicine, Becker, ENT, and Allergy. And then we have kind of a sub-practice of my own called Lozada Facial Plastic Surgery. So I was born and raised in Hawaii, and then I came out to the East Coast and went to school, college and med school at Penn in Philly, and then went to New York to do some training, and then came back to Philly and did more training, and then now I'm here working full time. So yeah.
All right, that's awesome. So before we hop into the case study, we'll just do a little background on your career now and what a day looks like for you. So just to get us started off, on a typical day, what do you do? Like, what type of patients do you see?
So typically when you're talking about plastic surgery, so there's kind of two things you should kind of know about in general, but there's many different routes to get to doing plastic surgery in general. So you can do a general surgery route where you do general surgery and then eventually do plastic surgery as additional training. There's a couple little nuances within there, but you're doing everything on the body. So you're doing full body, you're doing face, everything. You kind of get trained in all the techniques comprehensively. My father has actually did that, believe it or not. So so that's kind of like the typical plastic surgery that you think of that does everything. So I'm facial plastic surgery. So I did residency in head, neck, and ear, nose, and throat training. That was 5 years of training for that. And then I did an additional year training for doing facial plastic surgery, which focuses just on the head and neck. So it's mostly just head and neck facial issues. So, and you can even do ophthalmology and then do oculoplastics. So, focus a lot around the eyes and the eyebrows, and that's cosmetics in nature, and people kind of expand that for what they will. And even dermatology can go in and do. So there's a lot of places that touch on plastic and cosmetic surgery. But for us, when we're talking about plastic surgery, mostly what we're really focusing on is you're seeing a lot of consults during the day. And then, so your schedule broken up when you're doing anything that's surgical and the surgical subspecialties. You kind of have certain days that are meant to be in the office, and then you have certain days that are operating. So whether it's doing urology or orthopedics or neurosurgery or plastic surgery, you kind of have 2 or 3 days a week. It depends, but let's say like 2 or 3 days a week where you're in the office, and then 1 or 2 days a week, or depending on your schedule, where you're in the operating room. So you see the cases in the office, you book them, and then you do the cases in the operating room, and then you see them back in the clinic. And that's kind of how it works. So, people in an ENT world, let's say in my background, people are presenting with problems like ear problems, neck masses, thyroid problems, whatever it may be, a lot of medicine too. And you either treat them medically, or they have a surgical problem and you book them for surgery and you do the surgery and then you see them back. So in the cosmetics world, for what you do in plastic surgery, people, if it's elective plastic surgery, it's not a problem that they essentially need surgery for, but it's elective. So they're coming in and sometimes they have a specific problem. Someone says, I don't like my nose, I want to change the shape. I'm old, I don't like these things, or my skin, or whatever it is. And so you're doing a consult with them. And so sometimes, someone from, especially a facial cosmetic standpoint, they might say, I just am looking older. I don't like looking older. What can I do? Or they might have a specific concern. So sometimes you do a full analysis of their face and say, well, for this X, Y, and Z, we can do these things for that. That's how we would approach it. This might be some non-surgical things. This might be some surgical things. And they kind of, get some prices and they put it together and make a package. And they might say, I'm going elsewhere, or I want to do it, or I don't. And so the day is kind of a mix in terms of when you're talking about plastic surgery, usually a mix between doing consults, so seeing patients and talking about options, both surgical and non-surgical, and then seeing your patients before surgery, seeing your patients after surgery. And then there's a whole mix in plastic surgery that is a whole field unto itself that's called like non-surgical treatments. And so you're not really doing surgery, but in the office you can do a lot. So you've heard things like Botox, things like fillers. There's a lot of devices like lasers, a lot of devices that take out hair. a lot of devices that tighten skin, and those are all things that are done in the office. And so between all those things, that's kind of like how you mix your day up. And yeah, it's pretty fun. I mean, it's a good way to kind of spend your time and meet people and talk about things and get to do some procedures, get to use some really cool technology. Yeah, so that's pretty much the day to day.
So what's a typical patient that you would see? Just like before we hop into the case study, what are some typical patients that you would see day to day?
So I think the typical patient is, we definitely see a lot of rhinoplasty with our background. So we see a lot of patients that are there for, simply like, I don't like the shape of my nose or the appearance of my nose, or someone that might be like, I can't breathe very well, I broke my nose, I want it straighter, I wanted this, I wanted that. A lot of people who also just don't like certain aspects of their face or the way that they're aging necessarily. So, certain things like their eyebrows might be low, or they don't like certain wrinkling, or their face kind of have like loose excess skin or excess fat. And so those things that we can kind of target with treatments that matches with what they are looking for. And so what's just going to give them kind of like the best result. But similarly, everything isn't cosmetics. So, it's plastic and reconstructive surgery. So, there's a large portion of patients too that, they might go to a dermatologist, get a skin cancer cut out, and it might be too big in the office to get it closed up and put back together. So they tend to send them to facial plastic surgeons. And so, you can do a lot of skin cancer reconstruction. So you're, from all small little things on the nose to sometimes big things in the neck to all kinds of things. So, you can really work on that. And sometimes people who are coming after injuries or burns or other things like that, that you can really kind of work on things that are less, not cash paying or cosmetics, but also you're trying to restore the form and function of somebody's body part, if you will, and trying to work on it and making them the best that is possible for them. And so that's a whole nother facet, and is a very important facet too of what, facial plastics and reconstructive surgery is. So.
So in this, how do you allocate your time between surgeries, and how does your time use vary? Are there busy and slow times, or do you feel like your work is pretty consistent?
I think it's pretty consistent. You kind of like set, I think when you get to this point, through all the medical training that you have, you finally have a little bit more control over how you set your days and what you want to do. And so your days are really like however you want it to be, really. I mean, you can decide to only work from 8 or 9 till 4 or 5. You can decide that Monday is going to be a day where you see patients till 8 p.m. And so you really can kind of set that, but you want it to kind of be steady. And so, you're setting however much time you need for certain things. It's important to kind of stay busy, because you don't want big lulls, because ultimately when you're kind of in this, it's your productivity. So it's about, whether you're focusing on being busy or seeing patients or making money, whatever it is, but you kind of do want to stay busy. So I would say it's steady. You definitely want it to be steady. And I think most people kind of push it a little bit, in general in medicine. That's not specific to any specialty, but, people are a little overbooked or a little over whatever, people might not show up or whatever, and you kind of fold that in. And so you want to kind of have that buffer. And so people kind of push it a little to stay busier, just in general. So.
Yeah. So if you guys have any questions while we're going through this, you guys can ask it in the YouTube live comments, and we will be looking at those too. So one last thing before we hop into the case study. So from your perspective, do you see any problems working in medicine, and what surprised you the most about working in this field?
I will say that, especially having had a background in ear, nose, and throat surgery, and then doing that, you're dealing a lot with insurance companies and paperwork and getting reimbursed. And it's a big game, if you will, and understanding the game is important. And so, you start learning in your training as a resident. Some good residencies do a lot of training on this, and most do a kind of poor job at it. And where really, how you're measured, both how busy you are and potentially how much money you make. So whether that's, even if it's not important to you, that's how your boss essentially is going to be looking at you. And so a lot of that comes down to how you understand how the game is played and how you bill insurance companies and how you're able to maximize those things. And so, in some ways it's kind of, it is, I don't know if disheartening is the word, but in some ways it's kind of just, it's always never as much fun, you know, when you get down to it, to understand how much of the work you're doing is related to that aspect of it. When you're kind of with the insurance companies, it's a necessary evil, but you know, it certainly encompasses a large part of what you do. And it's not the most fun by any means of doing it. And so one of the nice things about when you go into the plastic surgery realm where things are purely elective and they're purely cash based is that you don't have to deal with the insurance companies as much. So, you know, there's two sides of the coin to that, you know, like it's very nice to not have to deal with the insurance. It's nice to say, this is going to cost X. And if someone immediately says, great, then you can turn around and do it. You know, we don't have to ask an insurance company for permission to do it or anything like that. So that is really nice. But on the flip side, for people that choose to do this or know that they don't want to do that, in the same sense, you're then choosing a specific population who are now paying you their own hard-earned money to do something and have expectations for that. So, you know, everything in medicine, wherever you choose, like there's never the perfect specialty. There's never the perfect, you know, subspecialty. The grass is always greener on both sides. And so you kind of just have to, in some ways, I always told other people and med students and other people that were trying to treat specialties or whatnot, in some ways you kind of just have to pick the patients that you don't want to see. You know, there's some people or a specialty you're just like, that's not for me. In some ways that kind of helps you weed out where you want to, what kind of patients you can tolerate in some ways, because patients are great, but there's some problems and things you like seeing and don't like seeing, and you're never going to have only things that you love all the time. There's always, you know, pluses and minuses. So that kind of sometimes helps drive people to be like, oh yeah, this is good. I can do this, you know, like I enjoy these people and these aren't so bad and all that stuff. So I think that's kind of one of the most common things that people will say, just because it takes so much energy and so much time in the appointment with the patient. And then afterwards, especially, you know, you're just working nonstop to just get the charts and all those things done. And so it's nice to kind of take that out and just focus on saying, hey, let's talk, let's do this, and cut out the middleman. So.
Mm-hmm. One common question I'm seeing on here is, do you work with PAs or any other professionals, or is it strictly just doctors?
So it's a good question. So cosmetics and plastic surgery is a very big field where there are a lot of NPs and a lot of PAs. There's a whole kind of like, there's a ton of people out there who are really interested in doing things. So becoming like a nurse injector, or becoming a PA who goes and operates with people and then, you know, does injections, does microneedling treatments, does lasers, does this. And there's so many people that have a big interest in doing that. And it is very hard to figure out how to break into it. And, you know, there's a lot of people that approach us to kind of figure out how to do that. And there really is no secret recipe on how to get in. It can be tough. And so someone kind of has to take you under their wing but it is awesome. I mean, there's plenty of people that I know who are PAs and NPs who are incredibly talented people that, you know, do really good work, whether that's with injectables or, you know, fillers or Botox or devices or whatnot, and who are some of the most knowledgeable people I've come across and have learned a ton from. So it is a huge field in plastic surgery and dermatology and this whole cosmetics realm. I mean, it's probably one of the it's a huge field, and also it's a place that a lot of people want to be, and the people that want to be there don't always know how to get in there. So but yeah, so definitely check it out if you're interested, because there's a lot of people, especially on Instagram and other social media outlets, people write blogs about this stuff too, if you're interested, that have talked about their experience, how to get in. So there's a lot of info out there if you're looking in the right ways of how to get into it.
How many surgeries do you tend to do in a typical day?
It depends on what it is. You know, it can certainly be one bigger case that might last, you know, 5-6 hours. Sometimes I would say mostly between like 2 and 3 is kind of like a standard thing. You know, most of the cases are around like 2 to 4 hours, I would say. So 2 or 3 is probably typical. And, you know, to give you guys some perspective, I guess, from like an ENT head and neck surgery standpoint, that's totally variable. I mean, you can do things on kids like, you know, taking tonsils out and putting ear tubes. Some people, those take really short times. You know, when you're in training, you would do 10, you know, easy in a day sometimes. And then sometimes you would do like these big cancer, you take out a cancer and put it all back together, and that would take 16, 18 hours for one case. So, you know, your day could be like totally different from a Tuesday to a Wednesday. So that was one of the things that I loved about that field, you know, like of doing head and neck. It was great. It was so variable.
So would you like to move into your case study now so we can see an example of what?
Sure. All right. So let me see here. So let me know. Oh, you disabled screen sharing. Let me see if.
See if it works now.
Perfect.
Awesome.
All right. So hang on, let me just make sure I'm sharing the right thing here.
Okay.
There you go. Okay. All right, can you see the PowerPoint?
Yes.
Perfect. Can you guys see my mouse or no?
Yes.
Oh, you can. Great. Okay, I've done these before where they couldn't see my mouse. Okay, perfect. So we're going to quickly talk about a case of what's called functional rhinoplasty. So we do a lot of nose surgery and facial plastic surgery, but I kind of wanted to give you this case because it's interesting. It melds kind of both the way someone's nose looks from the aesthetic or cosmetic standpoint, and also how it functions, something that we always are really critically concerned about. And we can do a lot of, you know, the nose is interesting, and then also do a lot of anatomy and kind of look at surgery and look at kind of a rhinoplasty case in general. So there you go. So here's a guy who showed up to my clinic. So he was 63. He had really, really bad nasal obstruction, meaning so he couldn't breathe through his nose. So he also had a terrible nasal deformity. So he'd broken his nose, I think he told me like 10 times. He'd been in this terrible car accident 15 years ago. And so he'd had terrible breathing from his nose for many, many years. And he said that when I asked him, I said, well, you know, one of the things we always like to say is that people come in all the time and tell us, you know, I can't breathe, or I feel stuffy or obstructed. We kind of want to see, you know, like, is it on one side always? Is one side worse than the other? Or is it kind of both? Or does it kind of switch? And so, you know, it's always more a higher yield when someone's like, it's always this side, you know, it doesn't switch. Then, you know, something like is blocking, something, you know, that's more mechanical, obstructive is there. And so he'd never had surgery on his nose. And he said that like, it's always his left side's the worst side. And so one of the things that we do, especially if we sometimes do these cases with some insurance, is that we always want to try, the insurance companies always want to make sure that we try what's called maximum medical therapy. So they don't want you to just rush to doing surgery or rush to do an MRI or something expensive. You know, they want to make sure that you've exhausted all your opportunities to treat somebody with medicine or something else first, which makes sense. You're trying to save some money. So one of the things that we do for breathing issues, when someone says they're stuffy or they're blocked up, or maybe they have a lot of dripping in their nose, is we try some nasal sprays. And so the two things that we typically do are using things like what's called Flonase, which you guys may have seen in the in any drugstore that you go to. So the generic is called fluticasone. It's a nasal steroid spray. So you kind of spray it once or twice in the nose. It goes on the lining of the nose. And the steroids really reduce kind of inflammation and swelling within the nose. And it's kind of like the first go-to medicine, not only for us as nose surgeons or ENTs, but even for primary care doctors. Like, there's very rarely a person that ever gets to my office with breathing issues who's not been told to use Flonase for many, many like months. So it's just something that is very common. You can buy over the counter now. And so that can help a lot of people if they have problems related to allergies or dripping or inflammation. And so that can really help. So they really want to see you use it for a month or over. And he'd done that. He'd done nasal saline, just kind of rinsing. And obviously it didn't help because his problem wasn't really you know, allergies or whatnot, his nose was just kind of jacked up. It was broken and he couldn't, you know, do anything with that. So here is pre-op photographs. So one of the things you have to understand about plastic surgery is that I'm trying to have an equivalent example, but so let's say that you do a surgery and you can use CAT scans to like measure how much better you did on your operation. You know, let's say you wanted to like, I'm just making an example, but you know, you did a surgery and you're like, I really needed to make this, you know, from 7 centimeters to 4 centimeters, or you needed to resect this cancer and get it all out. And I can prove it with imaging, like CAT scans and other things. That's great, but in plastic surgery, you don't have that ability. So for plastic surgery, photography and your pictures are your life. So having good quality pictures and reproducible pictures, meaning that the pictures that you take before surgery and the pictures you take after are super, super critical, because that's how you look at everything and that's how you critically analyze. So if the lighting's different, if the angle is different, if any of that's different, you know, it really hinders your ability to say, was that there before? Did it look the same? Does it look better? And so we analyze photographs all the time, and especially when you're doing rhinoplasty. So one thing that I want you to see, if you guys can see my nose, so, or not my nose, this guy's nose. So on the right-hand side here, this is his frontal view. So we call this the frontal view. You're looking straight on at his nose. If you kind of take a look at where the middle of his face would be coming up and down, you can see that his nose is severely twisted to his right side. And so you can see that the light kind of hits this, the light kind of reflects right here all the way down on one side, and the other side is right here. And the light reflex really shows you where his nose is. So you can see that from the upper third, the middle third, and the lower third of his nose are all shifted over to his right side. So that tells you that something's really wrong, and that, you know, obviously he's not normal in that sense. And when you get that history from him, it makes sense too. He broke his nose. So the other thing to note when we look at this photo on the left, this is what's called a lateral view. So we usually take about 6 or 7 pictures in a rhinoplasty set or any facial analysis set. But this is a lateral view from the side. And what you really got to look at here is that when you look from the top, if you follow my mouse, all the way down to the tip, you get this little dip. And this dip is actually what we call a saddle nose. And a saddle nose means that somewhere right in the middle of his nose, he was losing support of his nose. And so because he was losing support of the top of his nose, it's falling down. And likely, from experience and knowing how these things work, it's likely because of his fracture. So there's multiple fractures that he's losing support of his nose. So this could get worse over time. So probably his breathing and all these things that we're seeing is all related to the fractures that he's had from his accidents and whatnot. So what we found is we found that he had a really, really severely deviated septum. So one thing that we have to kind of go through is, what is the septum? So the septum is the middle part of your nose. So if you look where my cursor is here, we have 2 nostrils that you breathe through, and those are your airway passages. In the middle, that separates kind of the 2 hallways of your nose, is what's called the septum. And so no one's is perfectly straight. So everyone's is always a little bit funky in some way. And it doesn't matter if it doesn't bother them. But if you look at the septum from the side, so this picture on the right, this is cut in half looking from the side. It's called a sagittal view. So this is a sagittal view here of the septum. What you can see is that this is kind of the wall separating the 2 hallways. The front of the septum here, this blue is all cartilage. So the front part of the septum is cartilage, and the back part of all of this is bone, okay? So you can have the cartilage can fracture and break when you break your nose. The cartilage can be moved one way or the other, and it can make your nose passageway tighter. Or the bones can even have little jutting out projections one way or the other called spurs, and that can also cause the nose to be tight. And if you have those things there, then you can't breathe very well because there's no space to move, okay? Hopefully that makes sense. If not, I will back up. So the front of the septum is is right here, okay? So the front of your septum is basically, if I take my finger and I put right in the front, I'll feel the front edge of my septum right there. That's called the caudal septum. Where that caudal septum lies is really important, right? So if it's pushed one way or the other, that's really going to determine if I can breathe out of one nostril or the other. And there's people that you can actually see the caudal septum when you look from the bottom of their nose because it's so pushed out. And so here's an example of someone's nose, and you can see this line right here. That's the front edge, the caudal edge of the septum. And you can imagine that this person's nose cannot get any air through this nostril because that septum is all the way over there. Now, some people's noses are just like this in general. Some people's noses are because of this, because of surgery or because of trauma, they have something broken. So this guy had a severely deviated septum, and you couldn't pass anything through. So we couldn't pass instruments, you couldn't pass a camera. We have these little flexible cameras that can go in the nose, that can look all the way up in the sinuses and all the way back down to the vocal cords. You couldn't pass anything through there. So he couldn't pass any air through there. He couldn't do that for almost 10 years, which is kind of crazy to think about, right? Can you imagine not being able to breathe through one side of your nose for 10 years? That's unbelievable. And I could see too that the septum here, the cartilage part, I could tell just by looking at it that this had multiple fractures in it, just had breaks. So you could see that because now this whole piece is weak because there's breaks in it, it's not a surprise that you can imagine that the top of his nose had a little dip in it because this is all of his support. You can see that this cartilage part supports the top of the nose, and then the front part supports the tip of your nose. So if anything starts bothering the septum, whether it's from surgery, you take too much away, or a disease, other things like there's other kinds of diseases that eat cartilage, it'll make someone's nose go away. Something that typically, like people who use cocaine too much, it can actually cause a hole in the septum because cocaine constricts the blood vessels. And so if you use it too much and too often, the lining that covers the cartilage on either side, that starts losing ability to live because the blood supply is no good, and then you get a hole. And if the hole becomes bigger, guess what? You start losing support of your nose, and you'll see those people that have big divots in their nose, and you can just push their nose right into their face because there's nothing supporting the tip or anything of their nose. So the septum is really key for these surgeries. So one of the things that we did is we ended up getting a CAT scan for this guy to kind of see what was looking like in his nose. And so typically what we do for these cases, we'll use cameras inside the nose to kind of see with our own eyes and kind of get really far back and see how far back we need to go and just get a better view. So we use that technology, and then we can use CAT scans to kind of get a sense too of how bad it is. Now you can see this is a CAT scan. This is what's called an axial view. So the cuts are coming this way, okay? So you can see that this is the front of his nose right here. This is the tip. And his airway passage would be this black thing right here, going from the front of his nose all the way back. So you're going straight back with this cut. You can see that this part on my mouse is bone and this part is cartilage. And what you notice is that where the bone meets the cartilage is fractured, and it's completely touching the side here. So you can see that on his left side, he has no way of passing anything through there. So that confirmed for us too how bad this guy's fracture was. Also, the other thing to note too is that, remember we said his left side of his nose was really deviated. What happened with his septum is that his septum was pushed all the way where his nose is twisted. It's following this line, falling, but the front curved all the way over there. So almost like a C, call that a C-shaped septum. So just because it was here, it was twisted all the way at the front end, going all the way that way. So we're going to go quickly over some nasal anatomy. So when we do things, we really want to approach the bones and the cartilages to be able to kind of fix this guy's issue. And so what we do is called an open rhinoplasty. And so an open rhinoplasty basically follows this diagram down here, and we'll show a quick video before, but there's a little incision down here, and it looks like an inverted gull wing down here. And then we carry the incisions inside the nose after that. And what that does is it allows us to take the skin and soft tissues of the nose and completely just lift it off the cartilage, which is here, all the cartilages, and the bones up top. And so what that allows us to do is look everything directly, and then we can access both these cartilages. And then if we take these two cartilages, 1 and 2, that form our tips, if we take them and split them out, what we come onto is the front of the septum. So now we have access to everything that we want inside the nose. I was putting this in here as kind of just common things that we do in rhinoplasty. we really look at in the nose, we look at it in thirds. And I mentioned that before. The top third is bone. The middle third is called the middle vault, which is cartilage. And that's these guys right here, what are called the upper lateral cartilages. These guys form kind of a T. This is your septum. They form a T like this on your septum. And that's really the tightest spot in your nose, in the middle part of your nose. So that is really important about breathing. Okay. And then there's the lower lateral cartilages, which those form your tip. Those form all this stuff down on your tip. And so common things that we do in these nose surgeries, the upper third, we're talking about people that have bumps, right? So people have rhinoplasty take bumps down. The top is bone, the middle is cartilage, and other times the bones can be twisted. In the middle third, again, bumps, twists, and sometimes there's asymmetries in how one side is collapsed or the other isn't. And then a lot of things we do in rhinoplasty as well, whether it's cosmetic or not, is those tip cartilages. So people they have a big bulbous tip, or they feel like they have a ball on their tip, or they look different, or whatever it is. And so the other things that we kind of do are changes in how the nose is in relation to the face. So if you look at me like this, the projection of somebody's nose is how far projected out it is. So over projected or under projected. The other thing is rotation of a tip. So if you imagine someone's tip that gets rotated like this, imagine looking into somebody's nostrils. That's a really rotated nose. It looks terrible. And then less rotation is like this. So those are all things that we think about in rhinoplasty. So someone's septum is basically really messed up and it's really not working well, and there's a lot of fractures in it. Sometimes we have to take the whole septum out and then we fix the whole thing outside of the body, which seems kind of crazy. But one of the things that I want to show you is that, before we looked at the septum, there's this whole piece of cartilage here, but you don't need all of it. You really only need a strut in the shape of an L, 1 and 2, kind of like the support of a house. And you can see the L's here. The lower L is supporting the nasal tip, and the top one here is supporting the dorsum, or the top of the nose. And so sometimes when we do a septoplasty, just to remove some obstruction of the cartilage or bone, we can take out a window down low and leave an L-shaped strut of support so we don't mess anything up. Or if we really have to do a lot of work, we can take out all the cartilage and we can rebuild things in the shape of an L and put it back together so that we can then reconstruct things. So if things are twisted and misshapen, take it out. You can sew some pieces together, get support, put it back in, and re-support the nose. Luckily, we didn't have to do this for this guy. But we did do what's called an open rhinoplasty approach. So just like we would for a cosmetic or other kind of things for an open rhinoplasty. And we had to break his bones on the top third because they were twisted. So the only way to move them back is by making breaks in them so they're mobile, and then we can move them back more towards the middle. The middle third, we're going to talk about something called spreader grafts. That was really what helped us make sure that we supported this area of his nose so he wouldn't have any future collapse. And then also he had that little dip in his nose, which we call the saddle nose. So we wanted to build that up again. And so how are we going to build that up? With some kind of a graft or some tissue. And then finally, anytime that we open the nose, and you'll look at this in the video, anytime we open the nose, we ruin a ton of mechanisms that support the tip, right? And so you don't want to put someone's nose back together after it and then just have it drop. You want to make sure that you re-support everything that you do so that it stays the same. Once you've been there before, you already are wiping out support mechanisms. You have to know how to reconstruct those things. So this is what it looks like with an open rhinoplasty. When you lift, you make the incision down low and you dissect over the lower lateral cartilages. And you can see here are the lower lateral cartilages. You can see those little pointy things. Those are where your tips are. We call those domes. And then here's the top of the septum or the dorsum. Okay. So I'm going to see if I can can you see my other screen now or no?
No.
You're still on PowerPoint.
Yeah.
So let me share. So I'm just going to do this really quickly. Can you see this YouTube video or no?
Yes.
So here's an example of a surgery of doing an open rhinoplasty. And I'm just going to show it to you so you understand. They're marking, and this is, you might have questions, you might get lost. It's fine. This is complicated, but I want you guys to understand just what it looks like to open someone's nose by doing this. So here he's using a knife to make the incisions on the lower part of the nose. We call this the columella. And what he's doing is he's trying to make his incisions nice and clean so the scar looks nice, because it's the only scar that's there in the nose. And then now what he's doing is he's finding the edge of the lower lateral cartilage. He's finding one of the edges and he's making the incisions inside the nose, because our goal is to lift everything up. So you'll see now he's connecting incisions from inside the nose into the lower part here. And now what they're working on is trying to find out where the cartilages of your nose are so that we can lift the skin and soft tissue up. So he's going to work on doing this on both sides. And you can see now that this is the starting to see the cartilage of one of the lower lateral cartilages. And so he's trying to stay right on the cartilage to leave all the skin and all the soft tissue up. So he has his scissors in that area and he's going to just connect from here all the way out. And you can see that he's using the retractors really well to stabilize things. And now you can see here's the cartilage. He's pushing down on the cartilage. You can see another piece here. And he's really pushing down with his scissors, trying to just feel that he's staying right on top of the cartilage. And now we're getting more. So here's another example. I'll give you a better picture of it, just here. So he's opening up over the cartilages. And now this kind of looks like what we saw before. So here's one lower lateral cartilage, the other one is here, and now this is getting up to the more upper part of the nose, okay? So it's a lot of like, you don't really know where you are. When you learn this surgery, it's very complicated. And now he's getting up to the point right here on my nose, right here, above the lower lateral cartilages and exposing the top of what's called the dorsum. And that's actually the top of the septum, believe it or not. So now he's opening all this up. And now he's just basically lifting a layer of tissue on top of the bone. And so you can see he's kind of scraping on the bone just to make sure he's on the bone. So you can see now we're lifting up the skin all over. It's a very wide thing. So now what I want to show you is how we get to the septum. So one person here is pulling on one lower cartilage and the other person's pulling on the other tip cartilage and pulling them away from each other. Between the two, that's the front edge of the septum. So he's going to go and cut down until he finds the front edge of the septum, which is right there. Oh, right there. That's the septum right there. So you'll see it. Now he's going to basically go and expose the septum. And so now what he's doing, if I'll show you, this is your septal cartilage right here, okay? And so like I said, your septum is like this, and you have two cartilages called the upper lateral cartilages like this. He's on the cartilage on either side, and what he's gonna do is he's gonna cut these upper lateral cartilages off the septum. We will put it back together, but he's just exposing all of the septum. So he's now lifting all the layer of skin and soft tissue off the cartilage, which you see he's in a nice, he's just spreading with with an instrument, and now he's cutting the cartilage upper laterals off. He's going to do the same thing on the other side. He makes it look very, very easy. So a lot of that is really complicated. If you got lost, it's totally fine, but it gives you hopefully a perspective when we talk about what we're doing with this case. So now I'll get to share exactly what it is that we did. So on the upper third of his nose, we did osteotomies. Osteotomy means we break the bone. And so we had to break the bones. How we do that, we have these little things called osteotomes. They look like this. They start from basically the face of the bone up here, and we lock them into the bone right on the face of what's called the maxillary bone, the maxilla bone. And when we have them on the bone, they literally have an edge. You can see it. The edge engages the edge of the bone. And someone literally takes a mallet and just goes tap, 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 and you're tapping along, breaking the bone all the way up. And so we can make cuts laterally here. Those are called lateral osteotomies. And then we can make ones medially and more towards the middle this way. And what that does is your nasal bones are all right here. And if you make cuts all the way around, then you've mobilized or made the nasal bones mobile. So if my bones are twisted this way and I break them all around, then I can push them over, and then I hope that they stay there. Because unlike a broken arm where I can put it in a cast for 4 to 6 weeks, that's how long bones take to heal, right? Everyone's had some broken bone or a friend. We can't do that. We can't cast your nose for 4 to 6 weeks. So we kind of put a splint for 5-10 days and hope that they stay where they're going to be, and that you don't run into a door or play basketball or break your nose or whatever it is. So it's never good when someone pays a lot of money and then breaks their nose after, but it's definitely happened. So that's how we fix the upper third. The middle third, what we wanted to do is we wanted to obviously fix that divot, but the first thing we want to do is reconstruct the support of his septum because it wasn't supported. So what we do is we can take some of the cartilage that either he has in his septum, but what we really needed is we needed a lot of cartilage for this guy, and his cartilage was all broken. So we couldn't use his own natural septal cartilage. So we needed strong, straight, and a lot of it. And the only place you can get that from is rib. So you can either harvest someone's rib cartilage, or actually you can use what's called cadaver or basically a radiated rib, so donor cartilage. And so he wanted to use donor cartilage, and so you can cut grafts from that big piece of rib cartilage. So we cut spreader grafts, and what I want you to understand is that spreader grafts really help open up the breathing passages of your nose. And the reason why is because there's something called, when you look at this graph or this diagram up here in red, the septum is this straight up and down part, and the upper laterals are kind of making this inverted V shape. You have to imagine that the angle of that, how acute and how obtuse, determines how much space there is in the nose to breathe. And this is called the internal nasal valve. It's the tightest spot in the nose. It's where the most resistance to breathing is. So you can imagine if someone has a really acute angle, we want to make it more like this. Well, how can you do that? Well, if we separate the septum from the upper lateral, we separate it off, and we put a piece of cartilage in between, we've now made that angle from this acute, we've made it bigger, and the space is bigger. So that's kind of like the gold standard of giving more airway space inside someone's nose. So you can see that it looked like an inverted V. We cut it straight up and down, and we put this blue piece of cartilage, and now you can see that the angle here is more acute, and here now is more obtuse. And so what does it look like in an actual cadaver? Well, here, this is your septum in the middle. We cut the upper lateral cartilages off on either side, and then now they place 2 cartilage grafts on each side, and then you simply sew it all together. And so what that does is it really supports that top part of the nose, so it makes sure you're going to breathe well, and it's not going to have, nothing bad's going to happen to them. So that's what we did for that. I'm going to play. So you can see here, so I'm pulling the upper lateral away, and I have really big grafts that I cut down, but that's where they're going to slide into as spreader grafts. And I'm pulling the tips. These are the tips, they're out. So this was his septum here, kind of fractured. So now you can see the spreader grafts are those big pieces inside, and it's all sandwiched together. The septum's in the middle, 2 spreader grafts, and then it's hard to tell what's what, but all that kind of bloody mess is the upper laterals that I put all together again. And so I did his osteotomies, and now you can see his nose got straighter from that. So we'll talk about this next. So how did I fix the middle drop? So now I re-supported his nose, but I didn't do anything to build up that divot in his nose. So I have to build something up. So how did I do that? So I used a technique that's called diced cartilage with fibrin glue. So what I did is that we took a piece of cartilage and we made, with knives or razor blades, we made tiny, tiny, tiny little pieces. Just imagine like making little, like mincing garlic, if you will, right? With the cartilage, we made tiny, 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 tiny pieces. Then we put it in half, like a syringe, you know, like a syringe that you squirt through. We cut it in half so it looks like a little canoe. And you put the cartilage in there, and then you take some glue that we use inside the body, and the glue, when you put it in there, it mixes with the cartilage, and then when it dries, it looks, so here's putting the cartilage in, and here's putting the glue in, and then this becomes this little kind of like literally a gummy bear consistency graft. And so we can cut it and trim it to size, and that just gets slid in there. And so you have a nice kind of pillowy gummy bear consistency with not a lot of sharp edges because the cartilage is diced up really small and the fibrin glue is really soft. And that we can then, you know, do a small area, you can do a large area, whatever you need. So I'll play. So when we go through here, we'll watch the video again so we can kind of go through because it's really fast. So here's his septum. I was showing the space between the upper lat and the septum where I'm putting his spreader grafts. And so I end up cutting them down a lot because you can see the grafts are enormous. The rib cartilage is very big. And then I'm showing how you pull the upper lats off the septum. So now you can see his spreader grafts. I apologize. I can't find these original videos and they're only on my Instagram. So I had to take a video of my phone, which is so sad. And then I did the osteotomies, so again, and you can see how I'm twisting. I can move his nose now when I do that. And here's the gummy bear graft. Do you see that? So it's the shape of a canoe, an inverted canoe. And I was able to cut that down both in size and trim it however I wanted. So I got the right thing. And I kept putting it in, I put it out, in and out, and testing to see if that's the right augmentation that I want. So now the last thing that we talk about is how do we put it all together? Well, whenever we take those tips apart, we want to put them together, and we'll put them together with sutures, and we'll put them to, like, each dome gets sutures, and then the domes together get sutured. So that all has a level of support. But really, one of the things that people used to do most commonly for tip support was called a columellar strut. So they literally took a piece of cartilage. Imagine that this is a piece of cartilage, and between where the domes are, they put it like that. And you can see a diagram where here are the lower laterals, here are the domes, the tips. And in between here, we would just literally stick a piece of cartilage and sew it all together. And that piece of cartilage was supposedly strong enough, and it does work. It's strong enough that it won't let the tip kind of drop over time since you've been there in surgery. But one of the benefits of another technique is saying, well, what's the strongest thing around in your nose? It's actually the septum. The cartilage of your septum is connected to the bones everywhere. So it's really strong. So if we took some of those cartilages and instead we kind of sutured them directly to the septum, guess what? Your tip is now really, really supported. And that's a really common maneuver that we do. So here the diagram is showing you that here, the cartilage is in front of the front edge of the septum. See, there's some white space. But if we just push it back a little bit so it overlaps, then you can sew it all together. And now your tip is really well supported by the strongest thing inside the nose. And so this is what we got at the final result. This guy had a much straighter nose. He was a little wide, which ends up happening because we add those cartilage grafts in there so it can widen him. But he's okay, like that. He was fine with that, but he's way straighter. You can see here that this is about 2 weeks after, so he's still a little swollen up here. But you can see there's no divot anymore because that graft was placed right in here. And he was able to breathe without a problem for the first time in 15 years. So aesthetically, it was awesome. Functionally, it was even better, right? You changed his life in the way that he's able to breathe and do different things. Hopefully that's helpful. I'm here to take as many questions as you guys want. This is my email. Feel free to email me, my Instagram handle. You can DM me anytime. And that's that. I'll stop sharing.
That was incredible. That was amazing.
Was that good? All right.
Yeah.
Sorry, I talk a lot.
There were actually a couple questions relating to the rhinoplasty that I saw some comments on. Someone said, are you trained in closed rhinoplasty? How do surgeons know what to do without actually seeing inside of the nose?
It's a fantastic question. Let me, if you want me to, let me share one thing. So here's some things that I show with some of the patients when we have consults. So stop sharing. So here is some slides that so the difference between closed and open rhinoplasty. So we saw an open rhinoplasty where you're making an incision at the base of the nose called the columella. Here you can see, we recognize that here. And then we bring the incisions inside the nose. Well, in closed rhinoplasty, we don't do that incision here and all the incisions are inside the nose. But we can access all of this area in the same way that we do with an open rhinoplasty, but we don't get that view of the tip from straight down. So if we're going to modify those cartilages here, what we actually have to do is we actually free them all up and then are able to pull each one out of the nostril. Sounds kind of crazy, but that's what we can do. You would think, what's the big difference between the two? It's just a little incision. You know, through my training, we did a lot. So I had a bunch of mentors and a lot of rhinoplasty training, and one guy does all open and one guy does 90% closed. So it was really nice to kind of like get the best of both worlds and understand. And I personally really like closed rhinoplasty or scarless rhinoplasty. And it kind of, it's amazing to see. You know, I saw someone today 10 days after a scarless rhinoplasty. And at 10 days to 2 weeks, the amount of swelling that you get all over the nose is very different between the two. At 3 to 6 months, it's no different. It really isn't. But people are very excited when they pay for things to see the results sooner. People are very impatient. So just leaving this blood supply, and sometimes with something that's called lymph, it's like another channel of stuff. There's, you know, arterial venous blood flow and lymph. And so having that area of drainage, not only just this way being the only way, but now downward too, I think does make a big difference for swelling, and it makes a nice natural result. And so when I go through here, sorry about that. I'll show you. So like these are closed rhinoplasty, you know, results. Like if you can see this, you know, like we can do everything that you would want to do with changing someone with a big bump and a really big projected and under rotated nose to give them a nice feminine slope with a little bit of rotation and less projection. You can do all these things with scarless rhinoplasty. We can modify it. Look how big her tip cartilages were, and then now they're much smaller. It's not easy to do it. You have to have the training, but yes, like you have to have the training to do it. It's not something that's easy to just go and just start doing on your own. You can, but it's, you know, it can give you some heartburn.
Mm-hmm. Another question that I saw by Anda, they said, did you learn different techniques for different races? I am Black and I'm curious if one would receive a cosmetically appealing result for their features.
I think that's such a good question. When you learn, so especially when you're talking about cosmetics and aesthetics, there's so many things that are taught in books. And one of the things too, whether it's this or anything, right? But like you're taught all these things in books and things that you memorize, whether it's angles or measurements or this or that. All these things were made for white people. Like they're all the aesthetic of like what, like first of all, what is attractive, right, is totally subjective. But even if you try to quantify it and what people have and try to publish, it's all for white people. And so if you go by just that standard, there's things that certainly don't apply to other ethnic groups and other races. And so it is really important to understand what it is that you're trying to do, and what the aesthetic for that background is. And you really need to know, because especially if you try to change something that is, you know, important or unique or identifying, I mean, that's horrible, you know, so it's really not a good thing. My father's from Peru, so even though I look very white, I have a Hispanic background. So, you know, like Hispanic rhinoplasty is a whole thing, you know, like understanding what the requirements and what the typical look is and what you're trying to go for and what the challenges present itself. Asian rhinoplasty is a very, very big topic. The nose that you get with a typical Asian nose is totally different, and the things that you need to do and what you have to work with are totally different. Same with like an African American nose. You know, typically one of the things that's most common is that they talk that if you drop a line from the inner part of your eye, inner part of your eyes here, if you drop a line straight down, that's the appropriate width of your nose. It's called the alar base width. You can see that I kind of have a little bit of a Hispanic nose from my dad. So you can see that mine are actually wider than that. And African Americans in general are always wider than that. And that's not bad. You shouldn't go and change that on somebody just because it's wider than that. That's normal. It's acceptable. Maybe it's not for a white person, but you kind of have to understand those differences. So you can't apply things that you learn to everyone in general, and it is really key. And I think that's why it's good to go to someone who has experience or is that background or is that whatever. I think it makes a huge difference. Absolutely.
That's awesome. Thank you so much for all this information and for presenting the case study. we really appreciated it, and I'm sure people got a lot out of this. If you just want to pull up your page with your Instagram and email handle again, because I saw someone asking for that.
Oh yeah, let me open.
Yeah. So while he's pulling that up, I'll go ahead and talk
You
a
want
little
to share
bit.
this? Can you see it or no?
No, I don't see it.
I'll share it then. Perfect. There you go.
All right. So if you guys have any questions that weren't answered, you guys can either DM him or email him and ask him. So I'd like to talk a little bit about next week. We have an oral surgeon next week, so make sure you guys tune in for that. We will be announcing details. We will post details for this for the call this weekend. Make sure you guys hit subscribe, because if you aren't getting emails, if you guys subscribe, it'll give you guys a notification when we're going live. So that way you guys don't miss the calls, and we don't want you guys to miss those. So also, if you guys are able, please make sure that you donate so that we can keep this program running and sending out emails, because the emailing program does cost quite a bit of money. So if you're able to do that, please go ahead and do that. And just thank you again, Dr. Lozada. We really appreciate everything you just talked about.
Well, you guys are doing awesome. This is an incredible program with an incredible outreach, and all I can tell you is my only piece of advice is that things that ended up working out for me in my medical training and career that ended up being things that were good and cool were never something that I intended it to be. And it was just kind of like, I'm sure, Kieran, that this is something that you just started, right? And it grew kind of organically into something that was much bigger than you thought. And so, you know, when you have something that you like and are doing, just don't let it stop you. Just do it. And don't do it because you think it's gonna be huge or big or whatever. Just do it because you want to. And before you know it, those things kind of, you back your way into being important things that mean something and sometimes get you places that you didn't think you're gonna get there. So run with the things that you like and don't be afraid to do them.
That advice applies to all you guys listening too. Like,
Yeah.
got any projects that you want to do, just
100%.
All right. Thank you again. And I will see you guys all next week.